What band did you get the interview in?
I applied as a band 5, but the
Okay,
description says trainee slash specialist.
okay,
So band
okay,
5
okay.
slash band 6.
Okay, okay, okay. So, okay. So based on that, okay. So I just want to know because, based on the way they ask some of the questions here is based on what you're applying for. If it is a band 6 role, the most of the questions are not really around the technical area. It's more of the managerial aspect slash the administrative, but they still expect you to have a very good knowledge of the technical area of the job. Do you get? Which, of course, you have a little of it. So I would say a few now, then you can ask me your questions. I want to just say a few, then you can ask me your questions. So I already know what histopathology is all about. We deal with tissues. We also work with blood samples sometimes in the area of cytology and body fluids, where we deal with effusion and we deal with salivary glands, saliva. We deal with synovial fluid. That is the area of cytology. But basically, in the area of histopathology, we're dealing with tissue. So, like you already said, you're used to the sample preparation. Of course, you need to know what it means to get the sample down to the lab. And as you are discussing this, because of the role you're applying for, you have to be emphasizing the need of the quality area of everything you're saying. So when you're talking about sample preparation, sample collection, sample transportation, you're also trying to let them know that quality checks are involved. They are also trying to see the quality indicators involved, like are the samples received in good condition? Was there formalin in it? Was the sample well fixed before getting to the lab? So these are likely things that might affect the sample's preservation. Do you understand? Which in your role as a trainee or a specialist person, which is band 6 role, you're also trying. You are taking good check of did the sample coming in good condition? Was it properly labeled? Was the requisition form properly filled with the patient data, hospital number, and all other information required? The sample type, was it filled into the form? So these are what you need to know. Then when after from the sample collection area, you're taking it to cut up. You're taking it to cut up area for grossing. You need to know, of course, you might not really do more of grossing immediately, but you need to know what is being done there. Yeah, they do voice recording of their grossing. So once in grossing, you're confirming the site of collection as well, the cassette number. These are parts. The cassette needs to be labeled of the patient's case, labeled. So you're also talking about the once crossing has been done, where you measure the size of the tissue, the color, the consistency of the tissue, then bits of the tissue are taken into a cassette and now prepared for tissue processing. They are prepared for tissue processing. So at that point, they snap them. These are quality check because they want to confirm the number of tissue number of blocks they've taken for each patient. So that in case there's any missing case, they can always go back to the picture they've taken. And these are logged into they have already a file that has all of the work done that day. So why I'm saying all of this is like, so that when they ask you questions, you won't just say, yes, tissue processing. You're also talking about the quality indicators. You're talking about the quality check because there's a question about how do you ensure quality in the cellular pathology laboratory. So you have to talk from the pre-analytical to the analytical to then the post-analytical. So everything I'm saying now is still under the pre-analytical, the sample collection, the sample processing, then to the point of tissue processing. Tissue processing, there's already a machine for it. It's an automated procedure. You should also have to listen that you have a good knowledge of the manual procedure in case there's any downtime of the tissue processor itself. You switch to manual. If you have an idea of it, you can explain what the manual method. So during tissue processing, four things happen in the area of tissue processing: fixation, which you already talked about in the collection area. Then the machine also completes the process of fixation. That is what to be in the first keg formalin. Then from there, you talk about the dehydration, removal of the formalin from the tissue using alcohol. So there are different grades of alcohol that's been prepared already in tissue processor. Then you now move to clearing. Clearing is infiltration of the tissue with xylene to remove the alcohol from it. After that, there are also different three changes of that xylene in the automated process. Then you now go to infiltration with wax, the molten wax. So there are also 3 changes of wax. So these are the 4 things that occur in that stage. So once that is achieved, so once the tissue is once that is done, because of your experience, you might need to see like, what if there's a downtime in the machine? What will you do? Do you understand? You need to know what happens when the downtime. Maybe the tissue stopped in a particular stage of the tissue processing. So because of your experience, you know what the quality of tissue will look like at every stage. So you can say, based on my experience, looking at the tissue, okay, this tissue is still okay to move on from this stage. If not, the engineer needs to be called. The machine already have a maintenance schedule. In case the maintenance schedule was skipped, that might have caused that tissue not to process well. There's a log, a machine maintenance log, which you could check to know if it was actually done. So these are what like your level as a trainee should know. Do you understand? Ensuring the maintenance log is filled, ensure the maintenance chart is done, then ensuring that the reagents you're using are batch accepted. When we have new reagent, before we take it into use, we batch accept each of them using a control tissue. We'll take it through the tissue processor so that when the tissue are well processed, the machines are labeled, the reagents are labeled batch accepted, so they can now go into use. So after that, we now go into embedding. So after that stage, everything I'm still talking about now is the pre-analytical. So I'm still trying to, as I'm saying everything I'm saying, I'm looking at different errors that can occur and how to solve such errors. Do you understand? So these are the quality check you need to put in place, the quality control mechanism, and quality improvements, continual improvement that needs to be put in place so that it can be. So in the process of embedding, embedding is the preservation of the tissue in a wax for easy sectioning and for storage purposes. That is why we are embedding those tissue in a wax. So you're looking at what can occur there. Different things can occur there. They can bring a tissue without a case set without tissue. It could be that during the process of processing, tissues were not well capped and the tissue went lost. So if tissues are missing, you have to know about this because you might need to troubleshoot some of this issue. Another thing that can occur is if the forceps are not properly cleaned, you could transfer another tissue to another person while embedding. That is why you should always clean your forceps in between every tissue you want to embed. And you have to embed your tissue one at a time. Then the mode you're using, they have to be molten. If your molds are cold, it might cause the tissue when you're embedding it to form different layers such that it can pop up during microtomy. Then another thing is but when after embedding a tissue, you need to reuse that mode. That mode needs to be molten, as it needs to be hot before you can use it again. Then your working area needs to be very clean, so you don't transfer another tissue to another person's tissue. Then you need to like for automated process, because all of these processes are automated, you need to verify every case you do to be sure that you have done it. Then the wax you are using has to be a batch accepted wax, a good wax, so that it does not affect the quality of your case set once you are done. So after that process, we now go into microtomy. Microtomy is the sectioning of tissue to produce them into slides for easy microscopy, so we can visualize them under the microscope. It's a standard microtom or micron that is being used is 3 micron, but in some cases we don't use 3 micron. Like if we are cutting bone marrow, we use 1 micron. If we are cutting for sections we use for immunohistochemistry, we use 4 micron. And there are some sections we use 10 micron when we are cutting for molecular diagnosis. We call them PCRs, polymerase chain reaction, we use 10 micron. Then if they ask you that they need you to cut levels during the case of microtomy, levels is that after you've trimmed your tissue a little, you've taken your first section, you will now go 10 tons, more like you're trimming the tissue again 10 times before you take another tissue. So if they're telling you they want 3 levels, that means you're going to, when you take the first one, you trim again 10 times, take the second one, trim again 10 times. So we'll call it 30 micron because you're cutting at 3 micron. You're not going to be trimming in between 10 micron. So 3 times 10, 30 micron. So if they're saying they want deeper levels, these are some of the questions they might ask around microtomy. If they're saying they want deeper levels, that means you trim 20 times. You go 20 times, take the first session, go another 20 times, take another session, another 20 times. So this is called deeper levels. If they say they want shallow level is that they don't need you to trim so deeply. You just trim a little. They just want to know, to confirm the orientation. of the tissue. That is another thing, another embedding. Orientation is a very, very important thing because you don't want to embed wrongly. Then during microtomy, they will not chop off the diagnostic part that is needed. So you have to get the orientation, probably in the area of skin. You know, in the skin, you need to see the epidermis. Epidermis needs to be up so that when the blade is going, the blade can go through the dermis to the epidermis. When you're embedding a fallopian tube, you have to embed to show the lumen. So these are some of them that might be very tricky when you're embedding them. So another thing in microtomy, they might tell you how do you work smarter, not harder in microtomy, is that you have to ensure that when you are doing microtomy, you confirm that all the cases are complete because you don't want to cut some case and leave some case. And when they want to start doing microscopy and the cases are not complete. So it's best that all your cases are complete before you start microtomy. You cut at 3 micron. Ensure you cut to show the full face because you don't want to cut and not getting the full face of the tissue and then now send the tissue back for another cutting. You are wasting time. TAT is already been affected. So ensure that full face is gotten, the right protocol is followed. You follow what has been written in the SOP because all of things I'm saying now is already in an SOP. Do you understand? So you're following the SOP. Follow is you cut level, these are cut levels. And there's some protocols like here there's some protocol that some of their tissues have protocols. Let me just put it that I don't want to just say what we are doing here. Have protocol like the way they call prostate biopsies, the way they call liver biopsies, the way they call kidney biopsies, to ensure that you follow what the set protocols for the specific organs that has been given of you. So these are ways you need to work smarter rather than working harder, so that TAT will not be affected. The diagnostic area of importance will not be missed in the process of the tissue of giving a diagnosis. Then the overall patient satisfaction can be achieved. So from microtomy, you now go into staining. This is an automated process. Good thing once you have the right number of slides to stain, move it straight to staining. It does not make sense that you finish cutting your slide and the slides are just there, you are not staining them. TAT will be affected. You take them for staining. They will now have what we call send out, where we have to match the block to the slide, ensure that the right block has been cut and the full face has been gotten, the right orientation was gotten. At every point there's a check. Do you understand? So they do that in send out as well. Then all of this thing I'm saying now is what happens in the pre-analytical up to sending the slides to the pathologist. So the pathologist area is what we call the analytical area, where the pathologists view the slides. And there's another area which we could still match the area of the pathologist, the QC check. We also look at the quality of the stain has been stained by the staining machine to be sure it's staining properly. And during the course of the staining, they might ask you what you come and your machine stopped working, your staining machine stopped working, just like a tissue processor. What will you do? Same thing. You look at where the machine stopped. Was the slide well? Maybe it stopped in hematoxylin, for example. You look at the slide, yes, the hematoxylin staining has been achieved. So you move forward towards rinsing in water, differentiating in alcohol. You might now have to switch to manual if you cannot bring back the machine to work. Then you take it to your scene. Then there must have been a manual staining protocol that must have been accepted by the team, which you now use for staining because there's already a manual staining protocol, that must have been accepted. So you follow the manual staining protocol that has been accepted, you finish up the staining, then you can now start troubleshooting what might have been the cause of the downtime. Then if it is a leakage, you describe what you would do in the case of leakage. Let's assume it is xylene that is leaking. You have to ventilate the entire environment, open up the windows because of the xylene film. Then you have to, of course, you're wearing your PPE already, so you don't have any spillage on your body. Can you hear me?
Yes,
Yeah,
I can hear you.
Then you dap up the whole place with paper towel. Ensure that this paper towel are disposed of aseptically in waste in yellow or red waste bins. Then you record the leakage. You have to record the leakage probably an accident log or a spillage log or something. Then another thing that usually do is decontaminates the environment. So in case of xylene, you need to use detergents, soap to decontaminate the environment. So I'm not trying to ask you because they asked me a question like that. So when your machine, you have two machines and one is leaking and the other one is not in use, what will you do? I think it's okay. It's good that you troubleshoot the leaking one first because the other one is not working as well. Though eventually, what it means is that you don't have any machine to work with eventually. But at least you still need to say what you would do to the leaking machine. Then you now be talking about what you would do, which I've talked about the manual method you have to go. Then you also have a contingency plan. If the slides are so much, you might need to send out some of these slides based on the urgency. Do you understand? You send them out so that they can be reviewed by another case, another center. Then you have your slides back. But as these are going on, you need to let all the pathologists know that this is the issue on ground. You need to send out all your slides, or you need to do a manual method so that when they're looking at the quality of the slide, they can understand, okay, it is because it is manually stained, or it is because it was sent out. And of course, the clinicians need to also know that there's going to be a delay in turnaround time of the patient's result and everything. So in the analytical, which is the viewing of the slide, which I've told you I will do a little of it, or doing the QC check of our slides. Then the pathologists also look at the slide. So in the area of the pathology looking at the slide, can look at what are the errors can occur there. As I'm talking, I try to talk about the errors that can occur in different stage. In the analytical, if the pathology is not well trained to view slides, certainly is going to release wrong reports. If the microscope the pathology is using is bad, it could also give us a false negative result. Then the area analysis, we try as much as possible to also stain QC slides. Because in the machine maintenance and in the machine's schedule, we also look at the area of staining the control slides every day before staining the patient slide. Then the maintenance schedule of the machine, is it done as well? So you just look for a way to talk about all of these things. Maintenance schedule. The machine is a machine that has to do with changing of solutions. The solutions where there should be a routine for changing the solutions of the machine. Was the solution changed? Then ensure that the ones that needs to be covered, like alcohol, they are covered so they don't evaporate. Do you understand? Then the hematoxylin that knows that the metallic sheen can form on it, it needs to be filtered before use so that your slides don't start having brownish pigments on them. We talk about all that. Just look for a way to, say all of it so they will know that you understand what you are saying. So the post-analytical now is when the patient needs to get their results, the limb system. Of course, the limb system here works from beginning to end, from sample collection to release of result. So when there's a limbs downtime, certainly there's going to be a delay in turnaround time of patient results. So you talk about the limbs, if there's going to be limbs downtime, if the transcription of the results, if they're not properly transcribed, probably typing error or something. So these are what happens in the post analytical. Though the analytical is what happens in the it's what really we do. The pre-analytical is what we do in the entire laboratory. So the post analytical we don't really do so much about. You need to talk about them. So I think this is generally what we do in histopathology, but in each section now, like special staining, you need to now know different special staining that we do. Even if you don't know all, you can just know a few, like Jameson staining, like Widderfeld staining for leprosy, Gypsum staining is for Helicobacter pylori, Gram staining is for bacteria. Then we have this stain. There must be some other ones that you might not know, but because I have not really worked there here, but I get to see them do that. Rhodanine is for spiral chest, then Marsen micron for connective tissue. Then we have a couple of them like that. Then under ISC, I'm just privileged to, I'm working in ISC now, where it's an automated process. You understand? We have about 5 machines we are working we work with here because our lab is a referral lab. We receive quite a lot of requests for immunohistochemistry where we analyze over 200 antibodies to get. So we have the machine that does the entire staining. So you have to talk about the unidirectional flow of the lab such that you don't have any missing sample. Results are going out as soon as possible. So in the IAC unit, we also have this flow, the workflow as well, making sure everything is done together. So the cutting is done within the same space. So what we do is when there's a request for immunohistochemistry, we do the cutting ourselves. Now I said it before that for immunohistochemistry, we cut at 4 micron because these slides will undergo different levels of reagents going through them. So they need it to be a little bit thicker so they can absorb these things more properly. So in the immunohistochemistry, we cut at 4 micron. We allow them adhere well to the slide by putting them in the oven. After 1 hour, we'll take them out. Then in the immunohistochemistry machine, we have what we call the high and low pretreatment. So we have some. Am I too fast or am I
No,
talking
no,
out
no,
of
don't worry, don't worry.
points?
Keep it. You're fine. Don't worry.
No, you're not talking out of points.
And I
For the
continue. I don't want the flow to stop. That I have questions, but I want you to continue because I teach it. I teach people a lot. Sometimes when we start asking questions, the person forgets where he's. So you continue. Don't worry. I don't think
Okay,
you're
okay,
fast. I'll let you know.
okay. Well, I will soon round up. So, in the immunochemistry, we have the high and low pretreatment. So, we have some slides that go into the high pretreatment. So, the process has made it easy because they label this high on the slide. So, you know the ones that are going into high and the ones that are going to low pretreatment. The pretreatment process is just for antigen retrieval because these slides have the antigen in them and we want to stain them with the antibody. So the antigens need to be exposed in the slide. So when you take them into the low, for those that are for low, they expose the antigen. Then in the automated process, we have different things that happen there. We have other reagents they use, the mouse linker. There are some of them that use the mouse linker, the rabbit linker. Then we have the oxradish peroxidase, the HRP, the peroxidase, sulfuric acid, the wash buffer. These are like the other reagents, which if you do the manual, these are what you do manually, do you get? But the good thing about the automated process is that when you put in the slide into the machine, it will tell you everything it's going to need. So you just be feeding it. If you're very good with chemistry, it's easy to understand the immunochemistry machine. So once you put in the slide, to tell you I need the mouse linker, I need the HRP, I need it. So you put in all of that. Then it also uses the hematoxylin for the final staining to counter stain everything that has been done. So you can have a good clear um color differentiation of of the stain. So once the slide come out, just like we do in the main lab as well, like in the H&E staining, we also do a QC check before we send them to the pathologist for also diagnosis. So that is what really happens in whole histopathology area. And
All right.
can ask the questions.
I think you've really said a lot of things. Because of, I want to ask my own question. Let me explain what I want to ask because I think I might know what you are talking about, or I can say I know what you're talking about. But should in case Chine didn't pick that, okay, I want to ask you the question. Okay, one, you mentioned about orientation. So let's say somebody, you go for interview, they say, "What is orientation?" Because one of the reasons why, sorry, let me say this so that it will benefit Chine. Everything you said, there is no different with what you have said and what is going on in hematology or microbiology. The thing is that it's going on as per histopathology. And this is
Good,
where people mixed it. They think these are
good.
the same thing. You just need to take this, your experience here and put here. They are all the
Yeah,
same. Now,
yeah,
but let's say you go for interview, they say, what is orientation? You mentioned about making sure the orientation is right. Okay. I think
yeah.
I understand what you're saying, but yeah, what is orientation?
Okay. So orientation is putting the tissue the way that when you cut them, they could be of diagnostic purpose. For example, when you're embedding a skin biopsy, a skin has an epidermis and a dermis.
Hmm.
The standard way of embedding a skin biopsy is ensuring that the epidermis is up and the dermis is down. So that when you are cutting, when you put the tissue cassette on the microtome, the knife should go from the dermis to the epidermis because the epidermis is the hard part of the tissue. So once whoever hears you say the ones, yes, you understand what you're saying. This also applies to bone marrow. When you're bending bone marrow, it also has the hard parts and the soft parts. So the hard part is up. So we tend to embed them diagonally in a diagonal section, diagonal, so that
Yeah,
the hard part is up, the soft part is down.
yeah,
Another tissue, there are some tissues that the orientation doesn't matter. Like when you're cutting fibroid tissue, for example, fibroid is fibroid. You just place them in the center of the cassette. Another thing of importance is centralizing your tissue.
yes, yes,
Those ones just requires you to centralize your tissue. But orientation is orientating the tissue for diagnostic purpose. They are
yes,
two different things. Do you understand?
yes. I understand what
So,
you're talking. Now you
I
just
think
defined
it's the
another.
same.
So 1 minute, you just defined another thing that I wanted. So what is tissue? Some of these things have been opportune. So that's why because when we go for interview, what what okay, there are things when we say in hematology that if you don't work in hematology, you can never know that thing. Upon
Yeah.
all the signs that you know, these are terminology. So what is centralization or centralized? Make sure your tissue is central. You just said it now. So can
Yeah.
you define
Yeah.
it as well to us?
Yeah. So centralization is even when you are doing a diagonal presentation of your tissue, they need to be centralized. You don't put them at one edge of the tissue
Yeah.
and the other edge have all the wax. Even when you're doing even when you have to put your tissue diagonal, like they have to be at the center.
Yeah, that's
So
yeah, go on.
so all your tissue needs to be centralized, but there are now some tissue that the orientation is very important. Putting them diagonally, like fallopian tube now. You don't want to embed your fallopian tube and just put it standing. You embed your fallopian tube to put it down so that the lumen can be showing. Then we have to have some tissues like the ovarian cyst. When they give you an ovarian cyst, it's a wall of a tissue. So you have to embed it on edge. There are some of those pathologies, they will tell you what they want you to do. Like they will put it in the comments, embed on edge. Then some of them make it easy. They will dot the area that needs to be up. So they will put dots up. That means what you just need to do, just put it the way they have said it, dots up.
Okay.
The orange dot will be up. These are so why I didn't read this? You don't miss the orientation.
That's
They'll
fine.
tell you dots up. But based on experience, when you see a tissue, you should know what to do. Like for that ovarian cyst, it's a wall. So you have to embed it, you stand it. The edge will be on the center. Like I said, you don't embed your tissue in one corner at the other corner. All your tissue needs to be centralized. So the orientation now is ensuring you embed on edge for the ovarian wall. So you'll be seeing the wall of the tissue, embedding to show the lumen of the tissue, embedding to show the epidermis of the tissue, embedding to show. So these are so there are some tissues that don't need orientation, like in the case of placenta.
Yeah.
All you just need to do is there's some placenta that will even fill the whole cassette. So
Okay.
this one now you're not talking about center. Do you understand?
Yeah.
So you just have to ensure that the placenta doesn't go to the edges where you will miss them. So you have to be able to pack them together to fit the mold. So you're not talking about the type of mold you are using. You don't want to use a small mold for such a big tissue. So the mold you are using for a tissue has to be in line with the size of your tissue.
Yeah.
So tiny biopsies, you don't have to go and use a very big mold because they said mold.
Yeah.
You have to look for a small so that it will be easy for sectioning, so that you don't also lose the tissue when you are doing your microtomy.
Yeah, this is very, very the things you are saying, they are very, very important because one of the things, Chinene, I'm saying this, I'm going to allow you to ask your questions too, but one of the reasons many of us don't know that biomedical scientists, why we are there, like I tell people many times, is we're just there to any possible problem, anything that can make us to miss that proper diagnosis, we are there to detect it. That's just why we
Yes.
are there. And
Yes.
any question they will ask you, Sora, all the control things you are mentioning, the pre and all those things, these are the possibility, even the centralization or maybe orientation, these are things that could make us to lose that. And once
Do
you
you know,
lost,
recently I was cutting a tissue for immunohistochemistry, and the pathologist stated it there. It's a nipple with a
yeah,
skin.
yeah,
And when put in the comment, please don't allow the nipple and the skin go off the tissue because it's a big tissue.
yes,
So
yes,
it's easy for you to cut, and when you are picking, it will cut off because
yes,
of the size of the tissue.
yes,
So
yes,
that is why in embedding in the first place, it needs to be embedded properly to fit into the mold. So when you are also picking, you ensure that you pick it to fit into the slides.
absolutely. This is very, very important. It is easy for me to relate on everything you are saying. Just final question before I will now leave you and when you mention about, I know about 2 micrometer of the tissue thing that we cut and all of that. Then, but you did mention the fact that maybe when it comes to AHES sample or maybe other sample, I think you mentioned even the one that has to, I think it was a bone. You said about 10. So, is there any reason why this should be a different degree based on your own?
Yeah, yeah. For general H&E, I will specify each of them now. For H&E staining, we cut at 3 micron.
Yeah.
The standard is to cut between 3 to 5 micron. So everywhere we cut at 3 micron. That is the standard micron for you to visualize both the cytoplasmic and the nuclei staining. Then when you are cutting bone marrow, because like I said, bone marrow has hard and thin area. So they cut at 1 micron. Of course, the whole achievement is to see more clearly as well because of the size, the thickness of bone marrow. Then for PCR, which is a DNA testing. We cut at 10 micron. We cut at 20, not 10, 20 micron. So that we can see the scrolls. So that the tissue can come out in scrolls. Scrolls is like they'll be folded. Because we need a chunk of the tissue. So we cut them in that scroll so we can have chunk of the tissue for the DNA testing. Then we have some other ones to be cut at 8 micron for IMF immunofluorescence staining. These are cut in frozen section. These are another area of histopathology. Frozen section. We cut them at 8 micron for, like I said, immunohistochemistry testing. The light needs to be transmitted. We cut them at 8 micron. Then we also have some specials we cut at 8 micron as well for oil red O staining. It's a special stain they do on frozen section. They can ask you that question. What special stain do they do on frozen section? Is oil red O. We cut them also as 8 micron. Then we also have some requests that we also cut at a thicker micron because they want to see they want to detect it's a special stain. They will just tell you to just cut a thick section because they want to just see. I think they want to detect, is it melanin? They are not even staining it. They just want to put under the microscope to detect something. Some pathologists might ask you for such. They want to just cut a thick section. Then there are some times when you're cutting fatty tissue, it's difficult to get them at 3 micron because of how fatty they are. So you can increase your micron to 6 or 5. You will still get a very good staining with it. That is for fats. They can ask you when you're having challenges cutting fats, what will you do? You tell them you will increase your micron, then you allow the tissue cool very well in the eyes, then use a new blade to get a good section.
Okay, what if it was FFPE, like it's not frozen? Paraffin, FFPE now. Formalin feeds paraffin embedded. Yeah.
Mm-hmm.
And
What is
then
not frozen?
and it's fatty, like their fatty tissues are quite problematic with sectioning.
Mm-hmm.
What if it's such and then they ask you, so how do you troubleshoot sectioning of a fatty tissue? What do you do to get it right?
I just said it now. When you want to cut a fatty tissue, of course, it's formalin embedded now. Formalin embedded means that it went through formalin, didn't go through the other type of fixative because we have other type of fixative. We have Boyne's fluid, we have Zenker's fluid, we have other type of fixative. But formalin embedded that you used formalin to fix it, then you embedded it in wax. So when you want to cut such tissue and they are fatty, first thing is you cannot get good section at 3 micron for fatty tissue. So you need to increase the micron to 5 at least. Then you need to allow your tissue, the block, cool very well in eyes. Ideally, all your blocks should cool very well. Well, because you are trying to troubleshoot this particular sling, you allow it cool very well. Then use a new blade. So with that, you can get a good section. But if you don't even now get a good section, sometimes such tissues are not well fixed. So when you troubleshoot and you could not still get a good section, these such tissues are not well fixed. That means you need to do a back processing for such tissues. So you need to take them back to wax. If you want to do a rapid back processing, you can just take it to wax, leave it overnight in wax. Like when you melt it out in wax, there's already always let you know that there's already an already approved back processing that the laboratory must have accepted for reprocessing tissues that are not well fixed. Do you understand? But if there is not, what you could do is you take it back to xylene, allow the wax to go off the xylene for 2 hours. Xylene will remove wax. So when you take it to xylene for 2 hours, the wax will go off the tissue. Then you now take it back to alcohol. So you now do like how many hours in alcohol? You could do you could leave alcohol overnight or so. Then you now continue the process of processing again. What am I trying to say? If you don't still get a tissue, like I did I did an interview that they gave us a block to cut. Immediately I looked at the block, I said this block was not well processed, so I didn't cut it. Because no matter what I do, I cannot get a section. When a block is not processed, no matter what you can't get a section. So if a block is not processed, you do a back processing. You will process the tissue so you can get a good section.
How were you able to detect that it wasn't well processed?
When you look at the block, from looking at the block, you will know a block is not well processed. It will be looking fresh.
Your experience comes in, to be honest.
When you look at the block, it's not well processed.
What you just said, now that's just where experience comes in, unfortunately.
It will be looking fresh. A well processed tissue should have this brownish looking and to be firm.
Okay,
But this one will be
is that
stretching.
Yeah, like it looks fresh, like a bit
Uh, yeah,
dodgy.
yeah,
It's not dark.
yeah.
Okay, Chino, you can ask any other question. Otherwise, we need to allow Felista to go so that she has really tried.
Yes, thank you. I actually have
If you have,
I know you've said a lot of things and I've really grasped a lot. Thank you so much. But there's this question they normally ask that I don't even know how to start from because I know that in the lab everyone has got a section or a role or a task to carry out. And sometimes, like in my previous lab, we rotate. So when I'm asked this question and when I see it, I don't know where to approach it from. Is it from where you just how you just explained everything, the whole pre-analytical process, or is it just to speak about my role or task? They'll ask you, what is your normal day like in the histopathology? Sometimes, as in, I see this type of questions. What is your
What is your
normal
normal day
yes in
in the
histopathology?
you
histopathology?
go to work, what is your normal day?
Yes.
Those things are just common question, and this is where experience comes in again. But yeah,
Yeah. Your normal day in histopathology, because it's an histopathology question, you cannot just answer that question based on what you're doing at that point. Do you understand? So
Mm,
take it through the way I've taken it.
yes, I
okay.
was going to say that. Sorry, I was going to chip into that because, like what I said earlier, Chine, these things are the same everywhere. So I don't know how it works in Histopa, but I'm sure that when you go to lab, people don't work randomly. There's always where people are, they know what they are doing per day. Of course, what you are doing this week may not be what you are doing next week, and this is why it's important, if you really want to talk about that, to talk about each of these very benches, in my own opinion, of that's your normal day. So it's dependent on where you are working, for example. And such questions, I always tell people, you can't try to answer them like it's not something you can answer. It's something that you have to say, for example. You have to. That is the best way to be able to approach such question. Do you understand me? Okay. It's just like saying, how was your normal day of looking after a child? So it varies, isn't it? So I think
Yeah,
depending on the bench where you're working, but it's important that that person is trying to know, are you aware what that goes on in each of these benches? And
exactly.
the way to go through,
Like such question now, you can approach it that when you come to work,
yes,
first thing is that you wear your PPE.
yes,
Do you understand? So when you wear your PPE, you now start talking about what happens when you wear your PPE. Then your working area, which is the pre-analytical, you clean up your working area, you look at your schedule for the day. Has the maintenance been done? Everything has a maintenance to be done. The my embedding section has an embedding has a maintenance like a schedule. Is there wax in the embedding chamber? Is there enough wax in it? Is the area clean? These are like some checks you need to do before you start work. Then because you're now histopath, they didn't just ask you what is your normal day in microtomy or what's your normal day in embedding. They asked you generally. Then you now say, okay, when I put on my PPE, I look at the maintenance as the maintenance log been filled, my working area has it been ticked, as the maintenance of course they expect that they're not asking you if you are working in under tissue processing. The machine maintenance has it been done? The QC of the slide has the QC of that day been done? You're ticking all of these checks. Then you now talk about, okay, the samples you received that day, did they go in line with the acceptance or rejection criteria? So you now say a story that hey, that on such a day like that, we received a sample and rather than looking at the acceptance criteria, it didn't match with the acceptance criteria, the requisition form was not properly filled, or the sample was not, or the formalin, there was no, we used to receive such samples like that. There was no formalin in the tissue. So we had to call the clinic to let them know that there was no tissue. So we understood that they didn't have formalin. So with the permission of my section lead, we had to take formalin to them in the ward so that subsequently we'll not be having such errors again. So, because talking like that.
does that make sense, Chine? Because is it this question can actually come in another way. The unfortunate thing we will prepare for biomedical science. In fact, all interviews, to be honest, I don't know if it has happened to you. Even at this point, I go for lecturing interview, and sometimes you've planned this thing this way, and it comes the other way.
Do you know, I did an interview recently. It's still in my trust, and I was preparing to talk about myself from the point of, okay, how I left school, how I worked in the private sector, how I went to the different thing I did. You get. So, but do you know the way the question came? Question came, oh, that in your
Concern,
CV, you wrote that you are assistant manager. So what did you do? So do you know it's the same thing? So I start talking about everything I did under assistant manager role, how I prepare rota, how I participate in meetings, how I settle quarrel. Do you understand? You start talking about how you make sure you send me for pipette calibration, how
yeah,
you monitor around time, how you ensure that root cause analysis is done, continual improvement training. Do you know you just start no, they ask it in another format, but you still
yes,
talk
yes.
about yourself.
It's always very important that that's why sometimes, let me also say this, Chini, I was going to tell you this later. When we are preparing for job interview, I always tell people, don't think this is what you are going to be asked. There's no such a thing. Just know that I have prepared for this. That openness help you to have a better way to approach any question. For example, do you know that what you just asked Mommy now could be asked, can you tell us about your experience in histopathology? There's no difference between
Exactly.
that and what you just asked her. It's the same thing.
Exactly. Yes. That was why I had to talk about histopathology from that perspective of pre-analytical,
But
analytical,
what
and
you told us,
post-analytical.
what that thing you told us is actually your normal day in histopathology.
Exactly.
So
Yeah.
this is why
Yeah. So I
this is
want you to also open your mind. Like, don't think the answer is far-fetched.
yes,
Everything you did in Nigeria in your private lab is a story.
yes.
How they will call you for results,
Mm,
how you will call out results. It's not histo, but it happens in histopathology too.
that's why, yeah.
For fine needle aspiration cytology, we used to call back patients for resampling when they don't sample well. In your lab, don't you we used to call back for another sample to come
Yes.
for repeat sample? So don't think the answer to any question is in abroad.
There is
Is
nothing.
within you. Is within everything you have done. Is within the lab.
I like
Even
it.
if it's not in histopathology,
I
it's
like it.
everything you have done, even while you're in Nigeria. So don't think the only thing about histopathology, you can just be measuring tissue. That is the difference. Just be saying tissue,
Issue, all
tissue.
right. Issue.
But everything you have done in your private lab is what also happens in histopathology. So don't be afraid to say you don't know if this is related to histo. No, it is related. So
Yes.
far, call blood, just call tissue.
Yes. Because can I just say, when I was in NHS, mommy, I was so that time when my two more science that time I was just doing my PhD. A lot of things was worrying my head. So when they asked me question during my competency, I would be going and be bringing big science. My lab manager said, Emmanuel, please, whenever I ask you a question, can you stay within what you are doing in the lab? So that made me to know that, I've told you this before, Chine, but can I tell you something? You'll be shocked that even the managers, even people interview, don't really quite know the science. They've so much done this day-to-day thing that is all they want to hear. Do you understand me? Sometimes when you are talking that too much science is
They
good.
want to hear that okay, machine broke, you had so much work, eh? And you came and you're the only one working, and you went to me that man, we have so much work now, what do we do? And they suggested that okay, let's get somebody from another unit. As easy as that,
Yes,
to come and assist.
yes, yes. That's what they
How
want.
you how
Yeah.
you work extra hour just to clear the backlog
Yes.
is something.
So those
How
part,
you have to take somebody said they were bringing sample and you have to stay longer to receive that sample, work on it because of the patient's first. That is it.
all right.
So it's not far-fetched.
All right, Chine, do you have any other question?
Yes, so but I don't want to keep her for so long.
No,
I actually, I
she's
actually have.
complaining. If she's complaining,
Okay,
we'll be
can I
trying to
ask question on anti this? I know it's general, anyways, but because of antibody here in IHC, can I ask question about antibody validation because I think they normally ask about it. I don't know how is antibody validation done?
Okay, let me put it this way. Okay, for antibody validation, sometimes when you have installation of a new machine, you need to validate all of these antibodies on that new machine. Or when you have some antibodies that are not running in-house, that you need to validate so that you can start running them in-house. So what we do is that we get different tissues. Some of them are already positive. Probably we have known cases. Let me use them. Probably we are trying to bring in prostate PSA. PSA is an antibody, for example. We are trying to bring it in-house. So we are going to look for patients that already have prostate cancers and those that don't have. So we get like 20 of those slides. we cut them, we stain them with this PSA. So what we do is that following the manufacturer's instruction, we might have what do we call it? Configuration dilution factor that must have configured that we should use. So we dilute those, we follow the manufacturer's instruction, we dilute it based on that. For the automated process, there's no too much calculation like we do manually. There's already, the machine will tell you do this calculation, so you do it. So you have that stain already, you already have that antibody already prepared. So you use it to stain over the period of, now I'm trying to bring in what we've also do in area of chemistry. Do you understand? We do it over a period of 20 days or so, or 20 rounds. Like what we do is that when we are trying to validate a new concentrate, when we have a new lot of concentrates, we're trying to validate it, we'll prepare it, we'll stain it for a period of 1 month. So every week we use that same stain to stain those set of slides. So we are going to, when we do that over 4 weeks, we'll now look at the staining pattern or everything. Did it stain well? Did it differentiate at did the staining level differentiate depreciate at any time? So if all of these things, then we also give it to a pathologist to review. So they look at the review of these slides and they say, okay, yes, it's staining well. So by the time the pathologist attests that it's staining well, you have also attest to it. So there's a documentation to show that this new antibody has been validated and it can now come in-house.
That's
Does that
fantastic.
really
Yeah, that
explain?
makes sense. I think what I would do is that maybe just not to keep you, I already have a lot of this in it on my video. You know, the thing is that we think is different. It's just like what you say, antibody validation. You could say analyzer validation. You could say sample validation. These are common words. You just need to transfer
Reagent validation,
reagent validation. Or sometimes you hear the word verification. Do you understand me?
verification.
Sometimes you hear the word authorization. So these are, of course, these terms I've already explained it on my video. But the thing is that these are something that we need to know. If I know it in hematology, if you ask me in histopath, I just transfer. Don't it, instead of mentioning whatever reagent that I use in hematology, I'll be mentioning the one of. Do you understand me? It's like I already have a video.
So unlike hematology that is blood they will be using,
Yeah.
but we are going to be using tissues, we are going to be using slides.
Yeah.
We'll cut those sections onto slides, then we'll now use those antibodies to stain those slides.
And sometimes, you know, the another difference that the antibodies are not the same here. Like the antibodies will be asked. Like the last time I was asked, what sort of antibodies do you use? Have you used in IHC?
Just say the three common ones for breast cancer: ER, PR, and HER2.
PR and HER2. Just those three.
As in as in first say those three common ones. We have over 200 though.
You have it was part of the ones you sent to me, mommy, right?
Yes. We have a lot.
So because the reason why
So you can I can list a few for you now. S100, Mela A, Sox10, Prime, P16, Gata 3, PIF, sorry, HMB 45, AC 1, Rose 1, PDL 23C3. Okay, now these are like the other ones. So we now have for lymphoma. Lymphoma has over 20. CD3, CD5, CD45, CD79, CD20, CD138, CD19, CK19, CK20, AE13, over 200 antibodies. But were you able to write down some?
Yes, I mentioned PRER HER2. So, and she asked, is that the only one? I said, that's the ones I've worked. Okay, yes, I also ALK, I couldn't complete it because I worked on non-small cell lung cancer as well during my project. So, I just mentioned that one as well. So,
Yeah. A lot. Hepatocytes, there's a lot.
in an NHS hospital, what many of us also need to know. I know that sometimes when we're looking for a job, we don't really know how these things work. But mommy and you know that. In fact, I know this because I've been an in-house that sometimes, even when you go for interview, like when they say, is there all? Sometimes they're just looking for a way to tell you, unfortunately, because they have someone inside they want to give that. So
That's just it.
sometimes it's beyond their feedback. Tell yourself, did I do well? If you have, sometimes those feedback is just because they need to find something to tell you.
Thank you. That's just one thing I've come to realize in life, even if you are a band one,
Yes,
give your best to your job.
yes.
at the time you will climb the ladder.
Yes.
So for the fact that you don't get a particular one that time doesn't mean you will not get another one.
Yes. Yes.
Just keep giving yourself the best. Keep desiring to know more.
Yes.
Keep desiring to know more. Keep in the little work you're doing, work it well.
Yes.
Like I told you, I did an interview recently in my band. I wasn't given the job, but I didn't feel bad because I know I did my best. And even after doing my best, I just knew I could have done better.
Yes.
So in life, I don't feel like I have achieved it. I could have done better.
Yes.
I could have said more. So if
Yes.
you don't mind, I can share you those answers. You read them, go through them,
I don't
prepare.
mind.
I will share.
I don't mind, please. Anything you can share. I just want to appear. I know from Dr. Emmanuel, I have loads. Just like you said, I'm someone that is very open to learning. I have attended a lot of webinars, trainings outside my state. In fact, London, Milton Keynes. Once I get any small holiday, my vacation is for learning. Is either I'm traveling out, I'm doing webinar, or I'm doing so. Me studying is not my. Even though I have a very tight schedule, I try to broaden my knowledge, equip myself,
That's
especially
it.
knowing that what it's done here is slightly more advanced than what we did over there in Nigeria.
Yeah,
And
yeah,
attended interviews, they always
yeah,
come with different perspectives. Even when you
yeah.
think you have known it already, so they still come another way. But at least the last one, just like I told Dr. Emma, I know I tried very well and I did my best. Even
That's
she
it.
was even arguing, just like what Dr. Emma said, there are some things you will say, you will know that even their own science has not reached that level. When I was explaining to her about acid methane and neutral methane
Yeah,
in Asian blue and pass, and I
yeah.
told
AB
that
pass.
acid methane decreases in colorectal cancer,
Yeah,
neutral methane
yeah.
increases. And she was arguing. She said, no, it's not. I said, no, I'm sure acid methane decreases in colorectal and but I was like, okay, maybe after the interview, maybe you can look it up or something. But I went back and checked. I did my research. I
In
know
fact,
these are also the stuff I looked at.
Chineke, let me tell you something that, in fact, maybe I'll tell you a lot of things of this place. These countries, let me not say it because I'm going to put this on the video, don't worry. But okay, I think I'll cut it off. Let me tell you something. Don't let anybody to intimidate you. That's like mommy said, and like I've told you. You see, if you come out of interview, you should know I've done what, not that you've done everything right. Are you getting me? But you've done something well.
Yeah.
The feedback most time doesn't reflect you. Take it from
Do you,
me.
do you know that? Do you know
I
that
did
I asked my
that.
manager for feedback? Do you know today they've not given me
They will
feedback?
not give you the feedback.
Yes.
Do you know we did practical? Practical, I'm very sure. I know they boast. Do you understand? I know they boast. Embedding. Even people that did that, the SLT student, what they call them, that's this student that does some specialist portfolio stuff that came to invigilate us for that. This thing. When one of them made was like, wow, that will give you 10 over 10 because apart from that, I section, I embedded pre-analytical like safety measures of wearing gloves, disposing the waste in the right bin. Do you understand? All of this cleaning up my area, all of these things were done. So till today, they've not told me the feedback.
They will not
And
tell
I
you.
will not ask
Yes.
because rather I rather read to improve myself to
Yes,
get better.
it's the same thing they did to me. 2 weeks, I didn't get feedback. I didn't even get you failed or you passed for 2 weeks after an interview. I
Can
had
you
to,
imagine?
one day I became so angry. I said, somebody just sat me down, wasted my time. I canceled my shift and everything. You couldn't even tell me you failed or you passed. I emailed them and said, you called me for an interview. It's 2 weeks. I've not heard anything from you. At least speak to me. I have that right to at least get a feedback
Yeah,
from you
yeah.
before they went, oh, even though it was a difficult decision, but we couldn't hire you because you were not the best candidate, and
Not true.
So
Let me tell you something. Let me
It's
tell you.
fine.
I have been in a lab where someone that has been promised that they will give the job was working while people are trooping in for the interview. You didn't get me. I didn't say the person came for interview. The person was in the lab working. We know they will give her, the job. But people were queuing up, killing themselves at the end. They all get unfortunate. They still give. Listen, don't blame the system. Are you getting me? Don't blame the system. The system trusts the person they already know.
Which is okay. Which
Yes.
is
So
okay.
you don't need to blame the system. But the only thing, because of NHS has made it in such a way that any job must be publicly added for equality.
Yeah.
That's why I tell people, interview like what you're doing now, Chinene, is to improve yourself. That is what is more important.
Yes.
The one that is your job, which could be the next one you're going to, this one you're planning for. Once it comes, it will come. But what many of us, when you don't have experience, when they start telling you all those things, you think you've not, no, it's not correct. Just take it from me. I said this based on all kinds of experiences that I've had. You know, when you get into the system, you will be shocked how much you know.
Yes.
Anyway,
it's fine.
Ada, thank you very, very much. Thank you very much. I really, really appreciate this.
Thank you so much. Thank you.
Thank you. Thank you so much.
That's right. Thank you very much.
I really appreciate your time.
Thank God. Thank you.
God bless you. All right.
Thank
Have
you.
a week ahead.
Everyone, you too. Bye.
Bye.
All right, Chinene. So how did you find it?
Honestly, I feel impressed, like what you said now, because basically everything she has been saying is what I know. Like I was expecting to, like maybe when she's talking, I'll be lost. But I have gotten sort of this encouragement and inspiration hearing from you, and then because all this while the fear is that is a entirely different thing here. So even when I'm coming to the interview, or even when they ask some questions and I answer and I go back and read again, I feel maybe it's because I've not really entered this NHS. Maybe it's entirely different. Do you understand? And that's why I have been so eager to hear from someone who is really, do you understand? And now that I've heard from her, it's not even so different like that.
That's what happened. The thing is, I'm happy I'm going to put this video. Of course, I'll cover everybody. One of the mistakes many of us make is, I don't blame anybody, is lack of experience. When somebody like me go for an interview and you tell me unfortunate, I laugh. I'm intelligent enough to score myself. Now, doesn't mean I don't know area where, one can improve where possible. Does that make sense? Okay. So, but there is something else I want us to improve, which I don't want to stress. I don't want to stress her. Does that make sense? What the area I want us to improve on is the fact that when we are answering questions, there are ways you need to answer questions, and that is where I'm going to build on from next time. First of all, there are things that you ask that I'm going to help you to understand. Then maybe, hopefully, I'll help you to understand it better. Then we can, because we're already more than 1 hour, okay? Then we can move on. When you say validation, verification, authorization, these three, so first of all, I want you to remove your head from histopath. Just remove your head from that now, okay? Because you could go for interview and they ask you, how do you validate automated tissue processing? Or how do you validate what's it called? How do you validate
equipment validation? They ask generally.
All those things are general questions which I already have on my video. Okay. Now, sorry, YouTube channel, I mean. So what am I trying to say? Once you know those things, what you need is to transfer the skills to what you are being asked. Okay. Now, why did I say what I said? When we say you need to know, first of all, I'm giving you a background of this. Before we can use anything in the lab, we don't know that it's working. Do you get? So the best way to know that something is working is to put that into test. And when it gives us the desired result, it gives us confidence that that thing is working. Okay? Right. Now, let's say a woman said, I'm pregnant because she missed her period. It means nothing as far. Don't get me wrong. Like, in quote, it means nothing. It's when we now get the strip and do the test. Are you getting me? And even when it is positive, for us to really find out the degree of that pregnancy, we cannot do the HCG concentration. The amount of the HCG cannot tell us. Now, what am I trying to say? What could make us to depend on the strip? I'm going somewhere. Or what could make us to depend on that HCG? Do you understand? Okay. Now, let me go again. Remember that in pathology laboratory, there's what we call qualitative analysis and quantitative analysis. So why are we going through whether it's present or absent or the degree and all of that? It means that whichever angle you are looking at it, we have put each of those angles to test. And it has given us a result that gave us confidence that this is what it is. I'm blood group O positive. I want to use something very simple to explain this antibody validation you are saying. I'm blood group O positive, and you bought anti-sera, okay? And I've told you I'm blood group O positive. One of the ways, if you are very sure that I'm blood group O positive, maybe you've done it, you know that I'm blood group O positive. How would you know that this reagent you just bought is working? Is by putting down my sample to test that reagent. If it gives you O positive, it shows that it's working in O positive. But you may also need to get O negative to show that it works in O negative, because they are not the same. Because in O positive, the D antigen is reacting. So even after you've seen O positive and O negative, you might need to check A positive and A negative. Do you understand me? It is when you have done that, you can say, irrespective of whichever way you look at it, this reagent is working. That is validation. Are you getting me? Or verification, as the case may be. Now, once you have done that, that is why even in your quality control, we have what to call low abnormal. We have normal, then we have high abnormal. Okay? Now, this is in blood science now, by the way. So, meaning that why are we doing quality control? That's why in quality control, we can have level 1, level 2, level 3. So, some of those quality control, some of them measure lower amount of that very whatever thing, analyte. Are you getting me? Some measure normal analyte of that thing. Some measure abnormally high analyte of that. Let's say the normal concentration is supposed to be 2. So lower may measure anything below 2, and higher will measure anything above 2. Does that make sense? Now, when you do the quality control using lower abnormal quality control, the result it will give you is abnormal result, but it will be acceptable because that has been input in the analyzer as a lower abnormal quality control. Does that make sense? Okay. So even though the result is low, but it's acceptable because we want to find out that what we want to determine is that the analyzer is sensitive to detect any sample that has such low level. Does that make sense? Because if analyzer detects something that is just normal, so if it becomes abnormal, it may not detect it. So how are we going to know? So again, we can also have another quality control that shows us that it is normal, this is a result, or abnormal, this is also the result. Once you can see that the analyzer is giving us both abnormal result, normal result, and high abnormal result, then we can trust it. Does that make sense? What it then means is that we are saying, what that means is that we are saying that when we have a patient sample, there are 3 ways it can go. Either low abnormal, or it will go normal, or it will go high abnormal. And that is where calibration comes in. But I may not have time to teach you that. That is where calibration comes in. Because when you work in the lab, then you can see that sometimes, even though we say low abnormal or high abnormal, sometimes the analyzer is not able to measure some certain level of high abnormal or some certain level of low abnormal. What it means is that if the result is too low than the analyzer can be able to detect, you know what the analyzer will tell you? No result. Do you understand what I just said? If it is high abnormal than what the analyzer can detect, it will tell you no result. Does that make sense? So when it's telling you no result, it does not mean that there is no result. It just means that it doesn't have sensitivity enough to detect it. Do you know why I said all of this? When we want to draft our standard operating procedure, these are some things we put in place. When we try to optimize a method, these are the things we check. That is why we can now come up and say, okay, if analyzer say no result, it could be because this, that. Therefore, do manual testing. So meaning we have a SOP. In our SOP, it contains what to do when we cannot be able to get results. Does that make sense what I just said?
That means the result has gone higher than normal range, abnormal range.
Absolutely. So when we say antibody validation, forget about its antibody. What we're talking about is validation. What it means to a layman is the fact that we want to confirm that this antibody will do what it has been prescribed that it can do. So how can we be able to do that? We now find that any antibody this thing is, we'll find that it's known antigen. It's known antigen. And expose this antibody to its known antigen to see whether it can be able to
interact.
You understand me? React it or bind it. So if we find out that it has bind it, we also determine the degree at which it has binded it. Are you following me? Now, because there are two ways it can go. Maybe it didn't bind it. That means it shows that the antibody is not working. But very unlikely in what we are trying to talk about here. In terms of validation, now what we want to find out is that at what concentration can we use to detect a particular antigen? So it is from the validation process of the antibody that we can write in the SOP that anytime we're doing so and so test, we should use maybe, I don't know, let me make something up. Maybe we should use something like maybe 2 microgram or 2 microliter of that antibody. Why are we using 2 microliter? Because from the validation, maybe we have found out that 0.5 didn't show the result very well. Maybe 1.0 didn't show the result very well. Maybe 1.5 did not show the result very well. But we found out that from 2.0 showed the result. That's what we can say 2.0. So in antibody validation, okay, what you want to find out is that whether the antibody is specific enough to detect the specific antigen and at which concentration. So what it means, because you are worried about the concentration, you then optimize the concentration. And how will you optimize the concentration? By doing what we call serial doubling dilution. It is from that serial doubling dilution that we can now expose each of the dilution. Are you getting me? To the sample, the same sample. Then we can check the result. From there, we can say, okay, even though you're giving us result at this dilution, it's not quite clear compared with this. Are you getting me? From that, we can now come up. That's why sometimes in the SOP, it can tell you, maybe in terms of antibody, it can say, okay, you need maybe 2 to 5 microliter. Do you understand me? What it means that we've optimized and found out between that range, you will get what you're looking for. And again, part of the antibody validation is not just whether it can work or not. It's not just based on the concentration. It's also based on the duration of incubation. Do you understand? Because even though you have optimized the correct concentration, if you get the incubation wrong, it will not still work. So we also need to find out at which time can we incubate it? What will be the duration of the incubation? These are some things. So by the time you have worked all of this and test all of this, are you getting me? And you find out that, okay, this is what I work with in terms of the concentration. This is what I work in terms of the duration. Then you can now validate that should be the method we can use. Does that make sense? So this is what I'm saying. I said general now. So in validation, you are doing testing to find out the best way that thing can work. And once it's confirmed, then you can now authorize. Validate means I'm saying this is now good. We can use this now. Okay? And that is where all of this comes. So for us to be able to validate, we need to use a known sample to confirm or to validate unknown sample. So because this antibody, we bought it from the manufacturer, at the moment is based on what they said on the paper. Do you understand me? So we need to use our known antigen samples to confirm this antibody and at which concentration, at which degree. Does that make sense?
Yes.
All right. Okay. So hopefully we've gotten some things. What we are going to do next time, we can now look at, I want us to start answering questions. Hopefully today has been very helpful to you. So I want us to, in fact, after today, after what she said, I can tell myself that these things are all the same. We just need to find a way to apply them. You know, when we talk about this IHC, I was hearing her mention something like, I think she even mentioned something like PSA antibody. Are you getting me? Okay? That means we can, because when we talk about this IHC, even when we say like all those proteins that you mentioned, or whether it's CD, whatever thing, these are all proteins, meaning that they are all antigens.
Yeah, like the PRER HER2, they are for breast cancer.
Yeah, they are all antigens. So what we now need is to get the specific antibody that can be able to detect it. Now, there is something when she was talking to me, I also explained to her. So there is something she mentioned, linkage. Are you getting me? Those things are the secondary antibody. So the way it works is that, let's say this is my phone. The way it works is that why the phone is antigen. Okay? The phone is antigen. Your phone is antigen. When we buy primary antibody, are you getting me? That antibody, I want you to stay with me. That antibody will capture, if specific, it will capture the antigen. Let me repeat. Your phone is the antigen. We have gotten specific antibody to your phone, which is your phone antibody. And that antibody is a primary antibody. That primary antibody, what it does is to go and capture your phone, bind your phone. If you leave it just by binding it, you may not get a correct result. So that is why we need secondary antibody, which is where she was mentioning something like linkage. Are you getting me? Okay. Now, that secondary antibody, what it does is it also bind. Are you getting me? But what it does now is to detect. You can call it detection antibody. So in other words, what it's going to do is to amplify
the specificity.
Correct.
So that it will be detected.
Correct. So these are some things, these are science now. Okay. Now, that is why in that then, when we have the primary antibody that is raised from mouse, even though the secondary antibody may not be specific, but we must use, how will I put it? So in secondary antibody, let me
this case now, there's one example. The example I have is rabbit IgG, immunoglobulin G. Now the secondary antibody is sheep anti-rabbit IgG.
Yeah. So because what we need to know, when the primary antibody comes, your primary antibody can be your phone primary antibody raised in rabbit. Your phone is the antigen. So the primary antibody should be your phone primary antibody raised in rabbit. When we get to secondary antibody, it doesn't have to be your phone secondary antibody. What we want is secondary antibody that is raised in rabbit. Does that make sense? Okay. So when it comes to secondary antibody, in most cases they are polyspecific.
Polyclonal.
Yes, that's the word. Okay. So they are polyspecific, meaning they can bind to anything that is raised. Are you getting me? From its
primary is normally monoclonal. Why secondary is polyclonal?
All right. So you've gotten what I think you've gotten the gist. So these are some things I want you to understand.